Here's our second panel discussion, so I hope you're ready for a long haul here. This one is going to be on transplant. And we kind of picked this one as one of our topics just because I think there's very definite distinctions and ways of approaching and thinking about transplant. So we thought it'd be very, very important to have this talk. So our guest speakers for this are Dr. Chung, Dr. Greg Yanik, who was there yesterday, Dr. Yamashiro, who was part of the relapse session yesterday, and then our fourth doctor is Dr. Bolotin. It's Dr. Ellen Bolotin. She is an associate professor and staff physician in the Bone Marrow Transplantation Division of City of Hope in Duarte, California. She received her MD at Leningrad Pediatric Medical School in Leningrad, Russia. She also received advanced medical education at Central University of Hematology Oncology and Transfusion Medicine in Moscow, Russia. She was an attending physician in the Department of Emergency Medicine at CHLA. She's a clinical research fellow at the Division of Hematology Oncology of Research Immunology in Bone Marrow Transplantation at CHLA, and she's a pediatric resident, or she was a pediatric resident at Children's Hospital Los Angeles, and she is now at the City of Hope. If we can have our panel come up, please. We're going to have Dr. Bolotin go first with her presentation.
Hi, I want to say thank you very much for inviting us. And this is the first presentation for neuroblastoma from City of Hope. And this presentation comes from 3 physicians in our group, Dr. Rosenthal, who is the director of the program, Dr. Pavlovsk, and myself. So, and this is what I will be talking about it. So we will be talking about the regimen for transplantation, which we name BMT, which stands for busulfan, melphalan, and topotecan. But it's very convenient to remember the numbers. And this is just the overview of why busulfan, and this is a theoretical basis. And the most, I think, striking thing about busulfan to us that, number one, it has a very good penetration pretty much in all tissues, including brain. And second, that this therapy could be based on the measured blood levels. So very few drugs that you actually can measure in the transplant. So this is the busulfan's side effects, which is well known to community. I'm not going to talk about melphalan. This is the mainstay of transplantation. Any regimen has melphalan in it. And this is how we come up to this regimen. We analyzed our experience at City of Hope for autologous transplantation, which we did total 121 in the past 10 years, I would say. And we looked at it, and what we did, we figured out that the major 2 groups of transplant we did, it was Ewing sarcoma and neuroblastoma. And what we looked at then, it's a survival in patients who had autologous transplantation with all kinds of solid tumors in our department. And the number is about 40%, but it's 40% at around 8 to 10 years and about 50% at 5 years, which is an average that probably the transplant groups would show you. Then we went back and we did the preliminary work. We analyzed the safety and toxicity of the regimens that we use, any kind of regimen at COH for patients who are undergoing high-dose transplantation. And this is what we figured out. So we made it very formal, and we'll look at any kind of combination of busulfan with different medications, cytoxin, etoposide, cytoxin, melphalan, cytoxin with combination with transplantation. And what we were looking for, if there were any additional side effects that comes out from combination of busulfan with different drugs. We presented this as poster presentation at Biology of Blood and Marrow Transplant in 2005. And what you can see from this, or maybe you cannot see from this, you know, so but pretty much if you look at the very right columns, grade 4 and grade 5, you see that this regimen had very minimal toxicity, especially in something that you looked at, such as veno-occlusive disease, such as gastrointestinal complication and pulmonary complications. This is just what we showed. We compared Bucide to Bucide combination with any other drugs, and we found there were pretty much no difference. And we concluded that toxicity was acceptable on this protocol. And we went through the regular justification, saying that the rationale for high-dose chemotherapy with stem cell rescue was to pretty much try to intensify the dose of chemotherapy and introduce novel combinations. And we were looking what kind of novel combinations we can get through. And what we wanted a drug which would not interfere with toxicity of busulfan or melphalan. And at that time, we have done almost all Ewing sarcoma with combination of busulfan and melphalan. And we looked at the topotecan, which had a lot of activities in all kinds of solid tumors. And most importantly, the topotecan does not have any interference with side effects of busulfan and melphalan. And therefore, we felt like it will be an excellent combination for transplantation. So we proposed to this hypothesis that the addition of topotecan to non-preoperative regimen, so we intensify and we propose novel combination, would result in better outcomes. So we wrote the protocol, and this is what we do, what we give. So we start with busulfan, which we give over 5 days. We measure the levels of busulfan. We adjust busulfan just as we do it in any other transplant. We also continue to measure topotecan as a research tool to make sure that the dose which is used is adequate. And we finish up the transplantation with melphalan. And I'll skip this. And this is what we have right now. You know, in our solid tumors, which we transplanted since the protocol was introduced, about 39 patients, the overall outcome is about 70%. And given it's preliminary data, but we actually did not observe acute toxicity of the transplantation. This is just the distribution based on the disease status. And I think the most important part is that we do transplantation in patients who achieve remission or very good partial response. We do not accept patients who have massive tumors into transplantation because we know that we cannot offer them better treatment. So this is the distribution of age. Most of our patients are between age 2 and 5. And then this is our overall data on neuroblastoma patients that we did throughout City of Hope. And you can see that our data is quite similar to what COG data proposed here. So this is data everybody wants to show, right? So this is our data on BNT. So pretty much we did not lose any patient to the transplantation. We observed some patients as long as a year right now. They were able to go through the subsequent treatment with radiation and biological modifiers. And this is our data. All patients were in a complete remission or partial remission. We had no ICU admission. We have mucositis grade 2 and 3. We have no renal failure, no VID. We have transient transaminases grade 1 or 2 only. We did have fever, which is a common effect in transplantation. So the cell doses that are given to our patient in average 6 million of CD34 positive per kilo. The engraftment occurs day 8 and 15, median 12 days. Platelets more than 25, day 9 to 22. Red cells engrafted between day 7 and 25, median 16 days. And this is our conclusion. Number one, I want to tell you that it's very preliminary data. We need to follow up on this data. We know that neuroblastoma has a very certain way to go. So, but what we felt that regimen was very well tolerated, as well as patient neuroblastoma and other solid tumors. And therefore, we believe that it could be a very good platform for the further development and looking into specifically biological modifiers and perhaps different way to deliver radiation. And this is what we feel like we would be able to accomplish for these patients, to take them through transplantation safely in a proper manner, but make them available for the further treatment, any kind of, which we name consolidation therapy. Okay, what we think about in consolidation therapy, it will be excellent platform for gene therapy. It will be excellent platform for tumor-specific vaccines. It also will be very good platform for TMI, and this is what City of Hope right now working on. It's a total marrow radiation versus the total body radiation. And the continuation of therapy, the agents which have multi-targeted activity, such as angiogenesis, epidermal growth factors, tyrosine kinases, and so forth. We also believe that it will be very good platform for immune surveillance after transplantation and the use of novel immunotherapy. So I was told to do it in 10 minutes. Okay. I want to say also that I want to thank my patients, so for being very brave, so for actually entering the trial. This is all trial. This is research trial, very formal. It's an NCI-approved trial, So, and I'm very honored to name their doctor. Okay.
Dave is loading me up. I'm a NANT investigator, and from all of us at NANT, from Bob Seeger, who's the director of NANT, Judy Villablanca, Kate Mathey, a number of people that have spoken this past 2 days, Sue Cohen, Heidi Russell, Daryl Yamashiro, who's talking next, myself. I can't thank all of you for helping NANT. I mean, in many ways, you're part of the backbone of NANT, so thank you. Now, I thought, in my few minutes, I'm just going to show a few slides. Again, I'm Greg Yanik, if you didn't hear me talk yesterday from the University of Michigan. I just thought I'd show you just start with the slide that, in essence, has become the backbone for why we do transplant. Is there a pointer here? So Kate Mathey published this report. This is a landmark study. This is CCG 3891. And CCG 3891 is and remains today the largest neuroblastoma trial done to date. And in this study, patients got a standard induction therapy and then were randomized to either get continuation chemotherapy or ABMT, which stands for autologous bone marrow transplant. So, and thus there was a common platform for the patients in which we could actually look to see was there a benefit from transplant. This was reported in the Journal of Clinical Oncology in 1999, and Kate Mathey was the lead investigator. The transplant arm had a 34% 3-year disease-free or event-free survival. The chemotherapy, continuation chemotherapy arm, in which no transplant was done, had a 21% 3-year event-free survival. The difference statistically was felt to be significant. It's this curve right here that has actually given justification for why transplant is now done as consolidation therapy for your children. I have to admit, many of us as physicians have looked at this curve over and over and said, you know what, guys? I think both curves stink. All right? I think we can improve on both. I just thought I would just show you, I just put this together just about a half hour ago, because I just thought I would just show you, just for your frame of reference today, just some of the transplant trials. CCG 3891, the successor study, COG A3973, was just finished a couple years ago. The CHOP and Dana-Farber Cancer Institute study looking at tandem transplants, and then Morris Kletzel's transplant at Northwestern looking at triple tandem. And I just put the number of transplants down in this column, single, tandem, and triple tandem. The source for the stem cells was either bone marrow and CCG 3891, stem cells for the last 3. The regimen CEM has been the backbone regimen for many transplant centers over the last 20 years with TBI, CEM alone. The regimen here is CE with Cytoxin and melphalan with TBI, and I ran out of room to put Morris's 3 in there. And then you can see the 3-year disease-free survival for each of the studies with the Kate Mathé single transplant, the preliminary results from COG A3973, and then Steve Grupp's double, and then the triple tandem. Again, the numbers are all variable also in part because Morris Kletzel's study only had 25 patients, Steve Grupp's had 97, COG A3973 has 479, and Dr. Mathay's study had over 500 patients. So it's hard to, in some ways it's comparing apples to oranges. And just as I showed yesterday, the predictive value of MIBG scans and my own Polish way of spelling scans. You know, I write chemotherapy much better, guys. And as I talked about yesterday, your MIBG scoring after 2 cycles, after 4 cycles, and after 6 cycles, depending on the degree of MIBG response, you can see that your disease-free survival, DFS, at 5 years was pretty low. If you had less than a 50% MIBG response after 2 cycles, less than 75% MIBG response after 4 cycles. And then if after 6 cycles of therapy you still had more than 3 positive MIBG sites, the 5-year survival in this study, reported again by Kate Mathé, was only 11%. At our center at the University of Michigan, we kind of have this backbone now that we look at the disease status at the end of induction therapy. We actually really look at the end of 4 cycles. And if patients are still MIBG positive, we typically shunt them towards an MIBG augmented transplant. And for MIBG negative, then those patients will go on to get a standard transplant. This has been the backbone, as I talked about yesterday, for our MIBG transplant trials, not only at our center, but at NANT, giving MIBG day -21, CEM chemo with carboplatin, etoposide, melphalan, day -7 transplant, and then local XRT. As I showed yesterday, I'll just kind of quickly show you these numbers again. We've done a pilot study at our center with 55% response. A phase 1 NANT study had 30% CR and PRs, and then we're now running through NANT a much larger phase 2 study. Just the last 2 slides. So MIBG transplants, just what my own opinion is, they're good therapy for bulky disease. It's actually a good immune suppressant, as you'll see why in a second. And a toxicity profile, at least for the MIBG itself, we don't find that the MIBG, and this is key, we don't find that the MIBG adds any toxicity to the chemotherapy per se. The chemotherapy regimen itself, the CEM, is fairly toxic in terms of a lot of organ complications, but we haven't seen significant additive toxicity. As we talked about yesterday, we're now looking at a high specific activity MIBG agent called UltraTrace, and a new study is opening there, just opened through NANT. We're looking at radiosensitizers with SAHA or verinostat, retinoic acid, as ways to improve the activity of MIBG also. And there's a new NANT study combining SAHA with MIBG. At our own center, we've been doing autologous vaccine administration of patients after transplant. We've now treated 12 patients. We find that MIBG may actually be a good vehicle to lead into that vaccine trials. And as I just started talking about briefly at the end of my talk yesterday, we're now designing a study where MIBG is given right before transplant. The transplant is done mainly just to suppress the patient's own immune system so that we can then give the vaccine made from the patient's own tumor back at 2 weeks, 4 weeks, and 6 weeks after transplant. And then we're looking at new chemo regimens to add to MIBG, and there's actually a NANT study combining irinotecan with MIBG that's open now. Oops, my last slide didn't make it through. Well, the last slide I just want to tell you, it was just published by Steve Grupp. I just made the last slide about 15 minutes ago, so it probably didn't save. But Steve Grupp in bone marrow transplant, it's a nice article if you want to look up the indications for transplant for neuroblastoma. And Steve Grupp said the following, is that there's 3 indications for doing transplant for neuroblastoma. 1, that you have a patient who has chemo-responsive disease in which the patient has now achieved a good response, a CR or a PR, and you feel that they're at very high risk for a relapse, in which case you're then using transplant as consolidation therapy. 2, You're using a novel regimen to try to augment therapy, but that regimen actually has a side effect that it suppresses your bone marrow enough that you need bone marrow rescue just to recover from that regimen. So it's allowing you, the transplant, just to use a novel regimen. And 3, if you're using a combination of novel agents that may have either cross-reactive activity, that may again lead to suppression of the bone marrow, that you need quick bone marrow recovery. Or that you want to reset the immune system, such as in our vaccine trials, or we want to reset the immune system to be able to give the vaccine. So when you look at transplant, I just ask you to consider 2 things. 1, what is the goal with the transplant? Is your goal to do a transplant, a high-dose transplant, to achieve better tumor kill of the residual tumor? Or is the goal to allow for novel therapies to be given for that patient, such as to reset the immune system for vaccine studies? So you really have to look at it both ways. Is the goal of transplant just to do a transplant itself, or is the goal of transplant to allow for novel regimen? And really, in some ways, it's that seesaw that you have to think about. Well, thank you. Let's see. Oh, damn. Let's see.
That one, yeah.
This is the combo. No. Oh, you can.
Yeah. So I'm actually going to, Greg actually gave most of this. And this is actually a presentation that Julie Park gave in 2007 at ASCO. And actually, Nikon actually was there as well. And actually, if you want to go to the ASCO site, you can actually look at the 2007 meeting at the educational session, and you can actually see her video presentation. And this is actually just condensed as far as transplant. So I'm going to be the poor substitute for Julie, who couldn't be here today. So as Greg mentioned, and people have said before, these are the components of high-risk neuroblastoma therapy. So there's the induction regimen, so the high-dose chemotherapy. Then there's consolidation with myeloablative therapy of autologous stem cell transplant. There's also local therapy with aggressive surgery, and also local regional radiation therapy. And maintenance is post-consolidation of biological agent. Greg has shown this curve as well, but the question was, as far as revisiting the question as far as hematopoietic stem cell transplant, and does a benefit really exist? And so this is the same curve that Greg showed, where bone marrow transplant had an improved outcome in comparison to continuation of chemotherapy. And so there's been a couple other studies that have been done, one from Kathy Pritchard's group and then from the German group as well, in which they appeared to, again, indicate that a transplant did better than non-transplant arms. So in the Kathy Pritchard's report, they used high-dose melphalan versus no post-induction therapy, and the overall survival was about 35% versus those patients who did not receive some sort of transplant. And then in the German group, which was reported in Lancet in 2006, the patients who got megatherapy did better than the patients who only got maintenance therapy. But you know, there is the possibility that the curves start to come together later on. So at least as far as the randomized trials, again, I think that's important. All randomized trials to date demonstrate improved EFS following autologous hematopoietic stem cell transplant. However, there were differences in the regimens. Again, Kathy Pritchard compared stem cell transplant versus no further therapy. The German group compared it with low-dose chemotherapy, and Kate Matei showed that in comparison with a higher dose intensive chemotherapy. So part of the hypothesis for the other studies is now, does increased dose intensity of hematopoietic stem cell transplant improve outcome for high-risk neuroblastoma? And so Greg already actually has shown this data, so we won't do that. But then the current study is actually the COG-ANBL-0532 study, looking at the introduction of topotecan into the induction regimen, increasing radiation to the primary site, and the question of single versus tandem myeloablative chemotherapy. So patients get their induction chemotherapy, they get randomized either to one transplant or the tandem transplant. All patients get local RT, and then get radiation to the primary site with a boost, and then the randomization between cis-RA plus or minus antibody. So that's, if you want, you can go through Julie's talk, and she can actually it's a very nice talk if you want to go with that at your leisure. So the part I'm going to talk to you about is actually allogeneic stem cell transplant. And this is the work we've been doing at the Children's Hospital of New York and at Columbia University. So there's been no randomized trial, but there's been non-randomized comparison of allogeneic versus autologous bone marrow transplant. And these were reports from 1989, 1994, 1994. So most of the studies themselves were done in the late 80s. And so there was an allogeneic transplant arm, an autologous transplant arm, and I'll just sort of go through some of the lines in which Graham-Posch had about 92 patients. There were about a 26% disease-free survival with the allogeneic arm, and about the same in the autologous arm with 29%. Landenstein also showed in 1994 there was a 35% overall survival, progression-free survival in the allogeneic arm, and the autologous arm was about 41%. And Kate Matei, with a relatively smaller number of patients of 20, there was about a 25% progression-free survival and a 49% autologous. So you might say, well, is there any big, there may be equivalent, but what was one of the problems, I guess, with the studies? One, it wasn't a randomized trial, and two is the toxic death rate. So this was a fully ablative allogeneic transplant versus the autologous. And so if you look as far as the toxic death rate, meaning those patients died because of their transplant, as far as the earlier studies from the 80s, it was 33%, and 18%, and 20%. So that is a significant amount of toxicity that you have, and patients dying from that. So I think that's very important to know as far as these earlier studies. And I think now that we're in 2008, I think our supportive care is actually much better. So the major limitations, again, are the acute morbidity and mortality. It's a very prolonged hospitalization. You can have gonadal failure, there's myelodysplastic syndrome, secondary malignancy, and cost. So the question is how can you get around these issues? And so Simo Slavin, 7 years ago, came up with the idea as far as what's called a non-myeloablative or reduced intensity hematopoietic stem cell transplant. And so here's your patient here, and what happens is this is if you say the recipient or the patient here, and you actually give back cells, these B cells, and you give this preparative regimen. But instead of getting a very high dose regimen, essentially you wipe out the patient's bone marrow and then you give a new bone marrow back in, which is classically what is done, the amount of sort of chemotherapy or sometimes radiation that you give is much reduced. And so instead of being sort of a clean the marrow out, nothing, and then it repopulates, it's actually much more of a gradual process in which the cells of the donor mix in and you get a chimera if you get. So some of the cells are from the patient and some of the cells are from the donor. And what then happens over time is that often you'll get actually a complete chimera, meaning that those new cells, those donor cells that you gave, actually then become the predominant cell in the patient. And so this is in a way to actually reduce the conditioning regimen that you might have. So if you look here, as far as if you look at sort of like these are different sort of transplant regimens, if you would. And so you can go from regimens that are sort of very low on the scale of myelosuppression. So if you just give 2 grams of radiation therapy, that's very relatively low. And if you give sort of more standard, if you would, as far as an ablative transplant, it's TBI-Cy, busulfan, Cytoxan, it's more on this end. And so as far as the regimen that we've been using that was pioneered by Simo Slavin in Israel is busulfan 8, fludarabine ATG regimen. And so that's on the scale of things, although it's not essentially sort of minimal, it's certainly much less than actually the fuller dose as far as myeloablation. So these reduced intensity transplants have been increasing over the past few years. And so initially when Simo Slavin in 1997 versus in 2001, I don't have the more later data, but they've been gradually increasing as far as the number of non-myeloablative transplants that have occurred. So, it's been something that people have looked at as far as leukemia, but as far as the question is what about solid tumors? What about sort of bulkier tumor, if you would? So Childs at the NIH reported on 19 patients with metastatic renal cell carcinoma, and they were treated with a non-ablative allogeneic stem cell transplant. 9 of 19 patients were alive at 287 to 831 days post-transplant. And something you have to know about metastatic renal cell carcinoma, it's uniformly a failed disease in adults. And so they felt that they would go ahead and try this regimen. And so in 10 patients, metastatic disease regressed. 3 patients had actually a CR, and 7 patients had a partial response. And so the onset of tumor regression, it wasn't an immediate thing, so it was actually much more of a gradual thing that occurred. And that goes along with what you're trying to do, and which I'll explain in a second, is get something called graft versus tumor effect, meaning that the graft, those new donor cells that you give, can they in fact react with, in an immune response, get rid of the tumor cells. And so this is actually from his paper, in which you look at day 60, and you look at all these little dots here are actually pulmonary metastases that this patient had. And then if you look at day 285, so many days out, you actually see marked disappearance as far as the tumor. So in this instance, this would suggest that there's a graft versus tumor effect, that these new donor cells over time start to react and affect and get rid of the tumor cells. Now, has this been done in other cases? And yes, it has. It's been done. It's been responsive that has been seen in metastatic melanoma, ovarian cancer, colon cancer, sarcomas, osteosarcoma, and breast cancer. So all these reports suggest that there can be a graft versus tumor effect induced against solid tumors. So what we wanted to do is say, well, can we in fact use this technique to actually get a graft versus tumor effect? But if you look at the Kate Matei data, say, well, autologous transplant, you would almost consider it to be the gold standard. And the second thing, which I never thought about, sort of resetting, if you would, the bone marrow, this is one way to do it, is can you give an autologous transplant first to essentially get your disease down to as little disease as possible, and then come in with your immune therapy, whether it's some other form, or in this case, allogeneic transplant. And so had that been done before as far as other diseases? And the answer is yes. And so Corrella's actually shown this with both lymphoma, but also showed it with breast cancer as well. So they took 17 patients with heavily pretreated disease, and they gave them a tandem transplant. Instead of being tandem autos, one of them was a high-dose autologous stem cell transplant, and the second was a reduced intensity, sort of non-myeloablative transplant as well. And so 3 of the patients had a PR after the high-dose therapy, and they then developed a CR, complete response, after getting the allogeneic portion. And all those patients developed what's called GVHD before regression of cancer. And what does that mean? So I'm going to explain as far as what is GVHD. It's the graft versus sort of the host, if you would. It's actually that new donor cells reacting against the patient's own body. And so, in part, you want a little bit of that. You don't want too much of it. But you also want to figure out, can you actually make it such that that new graft also recognizes the tumor as well? And so, that's some of the data looking at these patients with metastatic breast cancer. So, it really suggested that a two-step, you could give an auto and you could give an allo in combination. So, our approach was to do an induction therapy based on the Morrison Kennedy N6 protocol, surgery, do an autologous stem cell transplant, and then give a reduced intensity stem cell transplant. And our goal was to try and see if we could get an allograft versus neuroblastoma effect. And this picture here, it's actually from a few years ago, is actually our first patient who was enrolled on the trial and is now disease-free over close to over 5 years from transplant and 6 years from diagnosis. So this was a team approach. My neuroblastoma team, along with Dr. Alice Lee and Julie Glade-Bender, along with the transplant, Dr. Cairo and Dr. Dabatia, and also Lauren Harrison. And so I won't go through the great details, but again, induction therapy, a consolidation transplant. We actually decided to look at a carboplatin topotecan regimen. But then patients would either get a transplant either from, if they had a related 506 or 606 related donor, or they get what's called a cord blood transplant, and they give up to a 4 of 6 cord blood transplant. So all patients got sort of, if you would, almost standard therapy of induction, consolidation, and then after that they got immunotherapy with the allogeneic transplant. And post that, they again got local RT and cisretinoic acid, sort of standard as well. So I'm not going to give you any of the other data, but this is our current curves, and so this is what we're. So we have 4 of 7 patients who received both autologous stem cell transplant and reduced-intensity allo transplant, who are now, there are 4 patients in this group who are 54, at least a median of 54 months from the transplant, and 63 months from diagnosis. All are in continuous remission. There are 3 patients, about 6 months, 7 months, and then around 22 months who relapsed. So I think what our data shows that, one, is that it's certainly feasible to do this as far as being able to do both an autologous stem cell transplant followed a reduced intensity allo transplant. I think we have a ways to go to figure out which are the sort of the best patients and how we can augment our allogeneic response. But I think it's certainly a feasible strategy to potentially pursue. So are we the only people to actually think about trying to do this? And the answer is no. So other people as well. And so this is some data, and I have to say, I don't know, this is just from the abstracts from the neuroblastoma meetings, which were held a couple of months back. So I actually don't have sort of great details on them. But Watanabe, and this is actually looking at cord blood transplant, so as far as, and they had 34 patients with cord blood transplant, and this was done up to 2006. And 14 of those patients previous had a stem cell transplant. And so I don't know what their particular conditioning regimen is. They had a relatively high treatment-related mortality rate, and I don't particularly know why that is. Their overall survival, though, was about 50%, and the EFS in the patients who came in CR was 41%. And interesting enough, and that, unless you think it's necessarily significant, is that those patients who were not in the CR was about 54%. I think this is early data, but at least it suggests that there's actually a possibility of an effect as far as allogeneic. Another way that they've looked as far as in Japan is as far as giving a different sort of donor source. And donor source in this case was actually what's called a mismatched, if you would. So we sort of look as far as getting sort of good match for the patient. And so this is 6 patients received an auto-allo stem cell transplant, and 3 patients received an allo-allo. And so some of it was from a haploidentical parent. So instead of being that your parents sometimes need to be a perfect match, this was, we know that was at least a half of a match, and that's what they used. And so 5 of those 9 patients were in CR in a median of about 55 months. So again, relatively reasonable data. And this is a treatment that was from Sweden, in which they looked at 5 patients who actually had relapsed or refractory neuroblastoma. Again, it was a haploidentical transplant. And they used actually an MIBG strategy followed by a reduced intensity transplant, and they what's called T-cell depleted that, and for relapse refractory neuroblastoma. So 4 of the patients had some GVHD, 1 patient relapsed 7 months after, and 3 patients are in CR 25 to 27 months after stem cell transplant. So relatively short as far as its follow-up. And so lastly, this has been a proposal that was initially tried to go through COG, but it's actually going to be done independently, actually at a multi-center institution. And it's been really pioneered by Sandeep Soni, who's at Nationwide Children's Hospital in Columbus, Ohio. And it's going to be looking at allogeneic transplant. And you don't have to read all this because it's really pretty complicated, but we're going to try and do it in patients either in CR after relapse therapy or in PR with sort of not great amount of disease. And Dr. Soni thinks that he can actually get this open in September 2008, and there are potential 7 to 10 other sites across the country that are interested as far as opening this particular protocol for relapse patients. We're one of the centers that are interested as well. And so we'll see as far as, is this going to have some efficacy as far as in relapse neuroblastoma as well. Thank you.
So I guess I will just get up and sit down because we don't do transplants.
Well, you had on an hour earlier today, so you're here. So you want to moderate, or you want? Oh, come up here.
Okay, so which one's best?
We don't know.
Yeah.
That's the truth.
You know, I think the tricky thing is, and coming out of this, is we're all using different measures. And as I kind of just looked at the data that was just presented, 100% survival rate's great, but we're dealing with 7 patients, I think, is what. So how does one think, you know, if somebody's going through diagnosis and trying to figure out which track that they're going to do and trying to weigh these, how do they weigh that against, for example, the MIB treatment, where, you know, when we're looking at those statistics, I believe you were quoting event-free survival, but those patients seem to me like they would have been naturally selected to be your hardest cases because they had MIBG positivity going into transplant. Versus yours, if I remember from the 2006 ANR, you had like a really high concentration of MYC amplified kids, didn't you? So you had some kind of high risk things, and you were quoting event-free survival too, which we have to define, and then we saw overall survival and some different statistics. So how does one go about trying to weigh all of these options and try to make a reasonable decision, if you all could comment on that?
So you have first cracks. Go ahead.
I think that these are all exciting results, but to compare, first of all, you need to identify make sure this is the same kind of population. So I think the first question that you probably will want to ask is, are these patients the same risk group? So I think in general, stage 4, more than 18 months of age of diagnosis, is probably be a reasonably high risk group, and if that is the group that we are talking about, I think it should be comparable. Obviously, if you start looking at stage 3s and those are less than 18 months of age, that's a problem. Because many places, stage 3s are not treated with anything, such as Memorial, irrespective of histology, and only MYC amplified stage 3s are treated. And those patients, fine, they don't need any therapy to be surviving. So there's an issue that there's a heterogeneity in that group, clearly. Some may need therapy and some don't. So I think clearly restricting patients to a high risk group, stage 4, more than 18 months of age of diagnosis, will be very important. Now someone might say, well, what if it's just a patient with refractory disease? Isn't it bad in itself? Well, that's not true, because what we know is in young infants and young children, even though they have disease at the end of therapy, they still do fine. We actually have followed several patients who have persistent MIBG disease at the end of induction therapy, and they seem to do fine. The disease actually disappears over time. So you have a problem again in terms of sometimes comparing results if the populations were different. So I think that the first thing we have to do among the doctors is to make sure we are talking about the same disease. The second thing also is that in terms of outcome, we always talked about survival. At what point are you talking about survival? 3-year survival is probably too early. You need to look at 5-year survival. And I think 5-year survival is probably a reasonable endpoint. And if you look at all the European studies, which is really just recently published, particularly the UK and Italy, their results are not good. Their results is essentially 20% overall survival with transplant. So this is obviously a single transplant arm. And in a sense, you may ask, why do we not do transplant then? Well, we take a different philosophy in a sense. We essentially, the one transplant is probably not enough. We take the route of, well, if not enough, it's not doing as well, why bother? Just go on something else. But I think there are many different approaches. You can add something in, you can make it better. You can do double transplant, triple transplants, or auto combination to make it better. So I think it's a difference in approach and philosophy. Maybe there's no such thing as like which is better than the other.
You know, when I look at patients for transplant or for therapy, I actually take into mind 3 questions. And the questions I typically ask are as follows. 1, what's the level of tumor burden that patient has? Do they have bulky disease or do they have minimal disease? I.e., do they have chemo-sensitive or do they have chemo-refractory disease? That's the first question I ask. 2, I then ask, what are the quality of the stem cells they have? Do they have stem cells? What's the quality of those stem cells? Have they been tested to make sure they're neuroblastoma negative? What's the quantity of stem cells they have? And then 3, what's the clinical status of that patient? What's their organ function? Is this a heavily pre-treated patient that's been through so much therapy that they're not likely to tolerate a high-dose regimen? So every patient, you ask how do we decide between things? In part, we have to look at each patient individually and decide, do they have the answer to those three questions? Do they have bulky disease? Do they have minimal disease? If you have bulky disease, then sometimes looking at regimen, such as MIBG transplant to get quick reduction of the tumor, looking at an auto transplant first, as Daryl talked about, he does an auto allo. In part, it's to do just what I said. When I was talking auto to get some bulk reduction of tumor, and then the allo to get resetting the immune system. So if you have bulky disease, you want to look at a novel regimen that can give you quick reduction of bulky disease. If you have minimal residual disease, it's just refractory. You've reached a point that you just can't get past that level of minimal residual disease. Then you may want to look at novel regimens, whether it's vaccine strategies, other type of antibody therapies, other type of therapies in that clinical setting. Then obviously, as I said, we'll look at the number of stem cells, quality of stem cells. That may negate even transplant consideration by itself. And then three, I really have to admit, we do take into account the level of pre-treatment that your son or daughter has. How many rounds of induction have they been through? Have they been through a prior transplant? What's their organ function? What's their GFR? What's their cardiac function, hepatic function? All these issues come into play. So for how do we decide what role, what choice to take? In some ways, it's an individual basis when I ask those three questions for every patient that comes in.
Okay, so, I'm sorry. Can I do a follow-up to that real quick? Bad. So kind of going with what you're saying, could we say that it's potentially for families that are out there that are in this position, that if you're heading into transplant and perhaps you have bulky disease, or you have a disease that we can define is probably not chemosensitive, it is probably a good idea to consider some of these other options other than just an autologous transplant. Is that fair?
By all means, I would certainly agree.